I try to feed the five and it chokes. I try another line and I fumble. When I try the Foley, it's clear. My word crumbles without the nurse here.
Hey guys, we're back with DJ Nurse Bauer with some Z-Dog MD, reining in our concept basic mashup, Basics 2.0. Beware, the concepts included self, family, culture, diversity, spirituality, professional behaviors, mobility, safety, informatics, caring interventions, physical assessment, health and wellness and illness, tissue integrity, elimination, and thermoregulation are not in order. So they are on here, but they're not in order. Okay? Looking to rein in Basics 2.0. Let's start out with some safety. We got national safety goals. Looky here. Identify patients correctly. Improve staff communication. Use medicine safely. Use alarms safely. Alarms safely. Like don't turn off the heart monitors. Prevent infection. That's our infection control. Our PPE. We need to know all about which precautions we should use for what type of bug we're dealing with. Identify patient safety risks. That's our fall risks, our seizure risks, our elopement risks, 6 rights of safe medication administration, right patient, right medication, right dose, right time, right route, right documentation. This also leads right into our dosage calculations. We need to look at our rounding rules. We need to make sure that we are giving the right dose, the right medication, the right route, the right milligram, the right milliliter. We've got to make sure we're looking at all of those things. Okay, next. Safety, specific risks for related to developmental age. Okay, so these are your age-related risk factors. Infants, unintentional injuries are right up there. Suffocation, SIDS, falls susceptible to TBI. If someone falls when they're an infant, 3 feet, that's huge for a 3-foot person. Just think of yourself falling. If you are 1 foot tall, let's say, or 2 feet tall, and you fall from 3 feet. It's kind of like us falling from, a whole body taller than us. Being struck or by someone or against someone, maltreatment. A lot of times this is a care deficit that we see. For example, people don't know how to take care of their children, or are not educated enough, or they just don't have the means to take care of their children. For example, changing diapers appropriately. You'll see a lot of diaper rash. You could even see bugs in diapers. Even basic care things. In the Appalachian Mountains, we definitely have mountain mouth as a Mountain Dew, or what's happening is parents are not giving formula if they're not breastfeeding. However, they are giving Mountain Dew in the bottles. Gives them the sugar that they need to stay alive. However, the other nutrients that they are not getting from those supplements. Toddlers and preschoolers being left in hot cars. This is huge. A lot of deaths happening with toddlers and preschoolers being left in cars, being outside when it's cold outside. And so what happens is some people leave the car on in a snowstorm, and then they end up getting carbon monoxide poisoning. Appropriate car seat and booster seat usage. You can't leave the hospital anymore without getting a check. The safety check, you have to go in and make sure your car seats are in properly and your booster seats are in properly. You cannot turn your child around before the designated time. That shows that their brains, their muscularization is not, their skeletal muscular system is not up to par to withstand an accident with that booster seat unless it's used a proper way. Drowning, pools are a big thing, especially for kids that cannot swim. Unintentional injuries, falls, scrapes, burns, or like my child sticking a crayon in his ear and breaking it off, unintentional things. congenital malformations. So that's when we see a lot of the heart deficits that aren't caught in the infant years. Um, Chromosomal abnormalities, we're going to see more with the population that has Downs and those other chromosomal abnormalities. They're definitely going to have a higher risk of age-related development problems. Fires, burns, and suffocations. School-age children and adolescents. Oh, motor vehicle accidents, teenagers and crashes. Falls, playground injuries, overexertion. Children tend to go until they crash. We have to kind of remind our parents and remind our patients that they have to take it easy. When they start feeling that overexertion come in, they need water, they need rest, they need those things. Our toddlers, even our school-age children, sometimes they still need a nap, okay? And that way it gets that sleep requirement that they need. Bicycle accidents, driving, contact sports, any type of sport really there's any kind of contact, we see a lot of injuries. Experimenting with drugs and alcohol. Unfortunately, this is starting earlier and earlier. That's why it's really important to educate kids. And a lot of times you'll come in and you'll talk to children and be like, oh, well, that's what my mom and dad were doing. And maybe that's something that they're exposed to at home that's not really seen as a bad thing, or it's kind of put under the table, hey, we don't talk about that, or we're not really, we'd only do it sometimes. But your kids are exposed to those things, regardless of whether or not we have it at home or their friends or something have it at school. Aggression, fighting, suicide is huge. Suicide is huge. I don't know if you guys saw on Facebook, there's a little boy, he was 9 years old, that he is Downs, no, I'm sorry, dwarfism. He has dwarfism, and he was bullied, and he wanted to die. He was 9 years old and is already saying, hey, I want to die. I don't want to live anymore. A lot of times social media is just that tipper that a lot of these young guys need. We need to promote safe and happy living for these people, a safe environment for everyone. It's super imperative with our mental disorders. We have to recognize these early on so that we can get these people help before it becomes a suicide. Young adults, poisonings, drugs, narcotics, medicine, biological agents. Everybody heard about the Tide thing? Oh my Lord, chewing Tide Pods. What was actually happening with these Tide Pods is that soap such as Tide has like boric acid, has acid in it, and it was actually, they'll ingest this stuff and the body will try to throw it up. Okay, however, it was burning the esophagus, and what had happened in some cases that it had burned through the esophagus and caused the children to have a hole and to code. So we have to be really careful with this type of stuff and educate them that the stuff that you put in your body, yes, actually does have an effect. Motor vehicle crashes, malignant cancers are hitting young adults at several different, rates, and different things are definitely a developmental thing that we want to look for. Heart disease, it's starting earlier and earlier and earlier. We really need to look at the risk factors for heart disease in our young adults. Suicide, homicide, overexertion, dehydration, especially like this right before college. A lot of them like, I want to get into college with my sports or stuff, but they'll keep going and going and going. They'll end up dehydrated, overexerted, and with injuries. Middle adults, that's me. Malignant cancers, heart disease, I'm getting there. Obesity, well, we're already there. Poisoning, I don't have any say on poisoning, but drugs, narcotics, medicine, biological agents. we still have to look at this stuff. Okay, this is an environmental stuff too. For example, all of our patients that come in with, let's say they work at Terminex. And they go in and like they're just having symptoms. They got really dizzy after work today. Maybe they were exposed to one of the agents, the biological agents that they use that caused a reaction in their airway. So we have to be careful. We have to be mindful of these things. That's why, for example, in our assessment criteria, we actually ask people what they do for work, because that usually will tell us whether or not they're predisposed to some things such as chemical contact or radiation contact. Motor vehicle crashes, falls, suicide, overexertion. You notice the suicide is in all of them except for toddlers and preschoolers so far. Life gets a hold of all of us, and I think we really just need to be cognizant of what other people are going through, and really take a good look at how we treat people, including our patients, because just being harsh on them when they don't need it really can just tip the edge for those patients as well. Older adults, chronic illness, heart disease, malignant cancer, stroke, chronic respiratory disease, Alzheimer's, diabetes, falls, motor vehicle crashes, same things, suffocation, poisoning, fires, functional decline. So these are definitely related risk factors for your developmental ages. I would probably know the differences between definitely like infants and toddlers, that you're going to know that they have the SIDS and suffocation is something that's a lot different than even your toddlers. It seems like left in hot cars is something that's big for them. And let's see here, the inappropriate booster seats. School-age children, it looks like it's more like falls and motor vehicle crashes, playground overexertion. Let's do the young adults. Is poisoning was number one there. Maintaining a safe environment. Performing hand hygiene before and after entering and leaving the patient's room is always the best way to do it. Implementing fall risks when needed. Implementing fall risks, so we're going to be careful about all of those tripping things for our older adults. Like, for example, loose fitting shoes, rugs, those types of things you're definitely going to have to pay attention to. Other safety things, for example, in the home would be a hot stove. Our patients that love to cook but have dementia, we want them to use more microwave oven, or we're going to want them to use things with less high heat applications, because like a griddle sometimes will actually be better than an actual stove. It can be put away after use and kind of out of sight, out of mind, so that when people are cooking, they are able to be monitored a little bit better. Bed in the lowest position, back at the hospital and at home. We kind of, sometimes the high beds are really nice, but then our patients can't get into them or out of them. Maintaining a clear pathway for the patient. Again, those throw rugs, tucking away electrical cords, adequate lighting. We also want to be aware of their sensory deficits or their sensory overload. If they're overloaded, we don't want to have the lights on, the music blaring, the TV on for them. We will want to keep that environment clean and quiet and promoting rest. Wearing the correct PPE when entering a contact precaution room, and removing all PPE completely and appropriately before exiting the room. So that donning and doffing is really a big deal. We really need to be careful about our donning and doffing techniques so that we can keep our patients and ourselves safe. Okay, so everyone knows about coronavirus. What is coronavirus? Is it A, airborne, B, droplet, C, contact, D, standard? It is a droplet precaution, okay? While we would like to treat it as airborne, it is not. It is a droplet precaution. However, that means that within 2 to 3 feet of someone, if you sneeze, uh, then that person is infected. That is an infectious area. So those droplets contain the bugs, so you would want to wear a mask. You would want to wear like a face shield like mask. You would want to wear your gloves, your gown. Okay, and taking these things off in the appropriate manner is also going to help prevent that infection. Washing your hands, making sure you guys keep up with your own hygiene along with your patient hygiene. Preventing injuries at all times and understanding who is at higher risk and what physical implementations you must put under those circumstances. That goes right back to all of those risk factors from your infants all the way up to your older adults. Sensory awareness. I really like that. Emotional state. Okay, we can totally tell a lot about a person by their emotional state. Okay, so usually someone comes in and they're really even keen, and all of a sudden they come in and it's just not their day, and you're like, why does everybody keep asking me what's wrong? I'm fine. Usually there's something going on. We can usually tell. Their emotional state will kind of give us a tip off as to what's going on. Cognitive. Sometimes if there's a change in mental status, we can also tell that there's a safety environment problem going on. A lot of times with our dementia patients, it starts out very small. So they're able to kind of cover it. A lot of our patients note that it's like when it first started, well, I just thought I was being forgetful. It just happens with age. Okay, and really what it was one of my patients, they said we knew that there was something wrong when mom couldn't tell me what her keys were. She said that it was like she knew what they were. She had them in her hand. She could tell you what they were for, but she could not tell you that it was a key. And that was pretty scary for the patient and for the family members. Sensory awareness. So when your hearing's going, sometimes we don't realize that our sight is so bad. It's kind of like getting a new pair of glasses. You put on your glasses, you're like, whoa, man, I guess I really couldn't see. Is everything really this sharp? Okay. For our patients, it's the same. Sometimes they need that new set of hearing aids to realize that these old ones just weren't cutting it. Or they don't realize what they're losing, especially if they're living alone and they don't have that feedback from somebody, or they don't have a lot of family around to give them that feedback. Hey, Dad, like, you really can't hear me, can you? No or yes, and that's something that's huge, especially since a lot of our older population are at risk for the self-care deficits and the sensory problems, as well as the psychosocial issues like isolation. Knowledge of fire extinguisher locations and understanding the race sequence. What is race? Tell me, what is race? Do you guys know? You guys know? Look it up. Look it up. We're gonna go over that as well. So race, rescue the patient, alarm, contain, evacuate. Okay, and that we use that in the hospital as well. This isn't just here, it's a little bit of everywhere. There's definitely different codes that we can call. In the hospital, you'll definitely see a bunch of different safety things like medical gas zones, shut-off authority. You have to call respiratory therapy engineering department leader. These are things that you need to know. Usually they'll give them to you on your tags so that you can just look down and see. For example, like quality definition, model for improvement, plan, do, check, act, our integrity, cultural diversity, from our values. These are all things that are on your tags, and they're actually on my Cape Fear Valley tags too. So it's really cool. We have all those, and exceptionally engaged employees. It has all those things on there too. It's a really nice way to have all the information that you need right there. Again, remember race is, now I'm going to have to look at it. Race, rescue, alarm, contain, and evacuate. Placing oxygen in use. Sign on a patient's door will reduce the chances of fire from someone bringing in smoke or other flammable materials. Most of our campuses are smoke-free now. However, at home, you definitely need to put in a oxygen, no smoking, or open flame. So this means if the patient needs oxygen and goes home and has a wood-burning stove, it's probably not the best idea. They might have to look into updating or getting a new place of residence for their home use, because the oxygen and their heating source will not vibe. Also, for example, anything else like the heaters, you shouldn't keep the oxygen tank by the water tank. You shouldn't keep the oxygen tanks by other sources of heat. If they have a gas stove, this is also with an open flame, this is not going to be appropriate for their living and to go home. So these are all things you want to talk to with the care managers about, and things that you might want to ask about if the patient does need to go home with oxygen. I love this. Patient safety starts with me. Absolutely. Um, Patient safety starts with you. Cultural awareness, self-awareness, understanding cultural um, uh, education if the patient is self-eliminating stereotypes, assess the patient for falls, provide assistive devices, make sure they know how to use them correctly. That's a big thing, making sure. Anybody ever go and try to use crutches and don't know really how to use crutches at first, and you hibbity hop around and you kind of feel like, real great, I have pain medicine in me, I don't feel good, now I'm trying to use crutches and I can't do this. That's kind of how our patients feel. So it's really interesting to see that. I really like that you guys included that into the PowerPoint. Infection control and communicable disease safety. Okay, so that's our coronavirus right now, or Ebola before, H1N1, measles, mumps, rubella. Those are the things that we're really looking at for also those considered a safety. Mobility. Mobility is the freedom and independence in purposeful movement. Purposeful movement is the key. A lot of our patients, like for example at Highsmith Rainey, they have some mobility. However, it's not, a lot of their movement sometimes is not purposeful. Immobility is the inability to move freely and independently at will. Assessment of the patient can include interviewing, observing, physical assessment, and diagnostic tests. Make sure that the patient's pain level and different to make sure you assess the patient's pain level and different range of motion. So we want to make sure, for example, if they're having a neck problem, we definitely want to see how far they would be able to look left and look right, up and down. Nursing interventions examples, I really like this. Turn every 1 to 2 hours, okay? But if they're able to turn themselves, it's something that we're going to have to assess. So limit sitting in the chair to 1 hour and instruct patient to shift their weight every 15 minutes. Chair sitting to 1 hour, that's super hard, especially for our paraplegics because they want to be in the chair all day. Okay, however, they do need to continue to shift their weight. Every 15 minutes is kind of hard as well. We definitely turn every 1 to 2 hours for the immobile patients, but definitely shifting your weight as much as you can to try to make sure you are preventing the pressure wounds is imperative. Mobility, proper body mechanics. This is huge. Okay, body mechanics involves coordination between the musculoskeletal and nervous system and use of alignment, body, gravity, and friction. So, proper body mechanics, you want to lift something. Over here on the right, you have the guy that's lifting the box, okay? Plan your lift. You have to bend at your knees, not your back. Ask for help. If you have to lift something off the floor, it's usually helpful to have a partner. Widen your base of support. You do not want a narrow base because you can teeter over. Bend at your knees. Bend at your knees. tighten your stomach muscles. So you want to be tight, you want to have your stomach muscles engaged in order to do the lift. Lift with your leg muscles. Your leg muscles are larger than your back muscles. Believe it or not, they really are. Okay, you've got to lift with your legs. Keep your load close, and you want to keep your load level. So you have a lower gravity level. Okay, if you have a high center of gravity, and you put that load higher than it needs to be, then you're going to get top heavy. Keep your back straight. You want to keep that back straight so that you don't topple and don't injure your back. Here we're going to touch on the concept of self. It's a psychosocial development in the personal perception of self that forms in a response to interactions with others and the environment throughout the course of an individual's life. So self is encompassing. It's your view, your self-perception of the things and situations, outlook on your life. This is what makes you you, your individual's lifetime. Components include identity, body image, role performance, and self-esteem. A twin may have a different perception of their self than their twin. So it's very individualized. It's interesting because, for example, same genetics, but that one twin might have been exposed to another life circumstance, which makes them go a separate direction in their life. This is Erickson's theory. I like that this has everything on here. So from infant to 18 months, we're going to do that trust or mistrust. That's your psychosocial crisis. So these are the things. Trust versus mistrust would cause your crisis. 18 to 3 years, that's your autonomy versus shame and doubt. So if you think about it, your kids, when you yell at them or talk strongly to them when they're kids, they get that like, oh, everything hurts. So it's shame and doubt, and we kind of want to try to foster that autonomy piece for those children. 3 to 5 years old, it's initiative versus guilt. We're gonna do it, but what were you doing? So that guilt factor, that oh no, like it's a hard phase, let me tell you. I'm between 2 and 4 with my kiddos, and woo, it's difficult. But that initiative versus guilt is that phase, that psychosocial crisis that happens at that time. Notice that they say it's psychosocial crisis. It's a crisis at every stage in life, which is funny that we have, was it 1, 2, 3, 4, 5, 6, 7, 8 crises during our life. At least I should say at least. 5 to 13 years, industry versus inferiority. So we're doing well versus I'm not getting this. This is inferior. I'm inferior. 13 to 21, identity versus role confusion. We went over some of this in the first PowerPoints, and I want you to make sure you look over what these things is: trust versus mistrust, the autonomy versus shame, the initiative versus guilt. I want you to make sure you at least know what those are again and revisit those different roles. 40 through 65, oh, I'm sorry, 21 through 39, intimacy versus isolation. A lot of people are very committed to their relationships at this time. 13 to 21 is like friends and knowing who you are. 21 through 39, we're usually trying to find a partner, we're trying to settle down, we're trying to have kids, we're trying to do all those types of things in that particular time in life. 40 through 65, generavity and the stagnation. So we're trying to be productive still. We're trying to be up and up on our productivity versus being stagnant in our life at that time. In age 65 and older, our ego integrity versus despair. So some people have already hit despair where they're losing a lot of their family members and such at that particular time, versus the integrity, holding their ego integrity together. Elements of self-image. I like these different elements. I like this block: perceptual, cognitive, behavioral, affective, and subjective satisfaction. The descriptions are here for you to read. Mental image of the body includes perception of physical appearance and how one perceives his or herself when viewing in a mirror. So that's like your perception. Some people see something that's not there, right? How we feel that we feel about our body. Like, okay, I look pretty good, okay? Or I look huge, or I look too small, or I look too this or that. Includes beliefs and attitudes about one's body, as well as that's our cognitive, as well as to a degree in which the body image is valued, and the individual's level of investment in physical appearance. So that's your cognitive perception of yourself. Okay, so how I feel about my body, what I look like, what I feel about myself. So that's about your image, and how much weight you put on your investment and your physical appearance. Your behavioral encompasses your behavioral manifestations, may reveal cues about the individual's feelings and perceptions about their body. So wearing like baggy clothing or wearing very tight clothing shows a behavioral description of your self-image. Affective. So this represents feelings about your body in terms of both appearance and function, may be negative, such as shame and as embarrassment, or positive, like I pride myself on the way I look. And sometimes this is very skewed, and sometimes a lot of people have a hard time with this. Subjective satisfaction reflects individual degree of satisfaction with their body or as a whole in the terms of the body parts or regions. Like, okay, I'm okay. I've been working on it, so I'm pretty satisfied. Here we're going to start with your professional behaviors. Nurses convey professionalism by adhering to the dress code, maintaining calm demeanors, refraining from inappropriate electronic media use. Yeah, that's huge. Electronic media use can destroy our work behaviors, let me tell you. Demonstrating a strong work ethic, accountability, expected standards, advocacy. These are pretty good. Teaching and learning competence. Advocacy. I really like how you added the ANA Code of Ethics for nurses and emphasizes patient advocacy as a key concern. Nurses are able to separate their own ethical beliefs and advocate for the patient wishes. It has a lot to do with especially our end-of-life patients. Maybe we don't feel like that's something that we would do in our particular situation, but we are there to advocate for our patients' wishes. Advocacy for the patient, for the practice of expressing and defending patient needs. So for example, if someone needs a hydration, you feel that they're super dehydrated and you feel that the doctor missed it, you need to advocate for that patient, defending their needs, and it's such a component of your professional nursing practice. So it's part of your nursing practice to be like, hey, I think you need this, can you help me out? Or hey doc, we need to get some dehydration protocols on this for this patient, I think. Could you take a look at it? And then document everything that you find. Nurses are accountable for advocating for patient safety and needs at all times. This patient is not ready to go home. Okay, that is something that you need to tell the doctor. They are not ready. There is something wrong. They are cognitively not safe for their living situation. That's something that's super huge with our patients now that are going back home. A lot of patients are trying to have home care, but may require additional assistance on top of what they have. An example of being an advocate would be support the patient wishes even if it's against what their family thinks is different. So if our patient wants to be a DNR and their family doesn't want to, we still have to advocate for what the patient wants. What is caring? Beneficence, doing good, promoting excellence, doing what's best for the client, involves giving high quality care. I like all of these. Take into consideration internal and external influences to provide the best care for recovery. Okay, for recovery, we are caring for them for their best interest. This does include self-care. So caring is teaching the patient how to care for themselves. So for example, if the patient comes in with an ostomy, we want to teach them how to use that ostomy. We're going to teach them about the procedure. The doctor's going to get the consent. We're going to get in there and start teaching them how to care for themselves. By exemplifying a positive attitude and demonstrating compassion, our patients will get what they need. Okay, so for example, if you go in there and be like, oh, this stuff stinks, like, it's okay though, we'll get it. All right, or rather you go in there and say, hey, all right, come on, let's just try this. Oh, I just don't think I can do it. Well, let's just do it together then. Come on, you can do this. I know you can hold your hand there. It makes a big difference for our patients. Accountability. A nurse's competence or ability to perform their job correctly is a practical measure of accountability. I like this. All right, how successful were you at delivering the patient care? What compels you to be answerable to yourself and to others? So there were a couple different questions on the tests about accountability, referring to what you do, but how you do it. Okay, so are you accountable for what's going on? So for example, if you delegate something to a patient, to a assistant personnel, you are responsible, you are accountable for that delegation piece, for anything that's delegated. Accountability for your patients, giving the right things at the right time is being accountable, showing up on time, completing your tasks, completing your documentation. Spirituality can play an important part in your client's life. It can play an important part in your own life, and how you see things for your patients as well. So we have to be cognizant of that, and that's with our cultural and family diversity and beliefs as well. Relates to what individuals use or does for self-discovery. Coping. Okay, spirituality and coping go together hand in hand. How do you cope? Do you go out for a run? Do you exercise? Do you go to church? Do you sing spiritually? Um, do you sing? Do you use music? Do you watch movies? A lot of people cope different ways, but they find brightness, they find the sense of calm, the sense of peace in different modalities. Personal and subjective because it's different for each individual. Spiritual distress to challenge your belief systems or spiritual well-being. So that's something that challenges that. So often it can be catastrophic. So this is a death of a close family member, or this is a loss of a limb. This is a sensory loss. Can actually derail someone and they become spiritually distressed as well. Once belief systems are questioned and support is difficult to find, spiritual distress begins. Signs are hopelessness and decreased interactions with others. Interpersonal within oneself, I like this. Interpersonal with others and in the environment, and transpersonal with unseen higher power. These are really cool. Spirituality with each of these pieces, I think, is a conglomeration that once we know how spiritual we are, this is actually going to help us apply our things to our patients and to see how we can help them best with their spirit. Spiritual assessment can inform interventions that foster hope and incorporate patient spirituality as a resource for motivating the patient. I would be cautious on inviting hope, fostering that hope in patients that are terminally ill. They may have hope of feeling or having a dignified death, but it might not be a reasonable goal for them to have a hope for a longer life. There's primary, initial, and focused. Self-reflection of personal belief is your primary. Initial is identifying client religion. If any focus is going on as a nurse identifies the client's risk for spiritual distress. Spirituality is highly subjective, requiring development of rapport and trust along with the family member and the provider. These are all part of your caring interventions as well. Sorry I had to change some of the colors in some of these. They had really pretty colors, but the accessibility was not there. Um, I like this faith, beliefs, perception on life and responsibility, satisfaction with life, culture, rituals and practices, client expectations. So a lot of things, for example, are life and self-responsibility. If you were all of a sudden, if you were the head of a family and then all of a sudden now you're sick and you are no longer making that decision maker, that can really have an impact on your personal spirit and your personal self. I like this. Fika, faith or beliefs, implications or influence, community, and address. How would you like your healthcare team to support you spiritually? Maybe this is going for a walk outside. Maybe this is taking them down to the chapel. Maybe this is having the reverend or the priest or the shama to come up and see them and visit them in their room if that's available for them. Caring interventions. Caring should be at the center of all therapeutic nursing interventions. Feelings of caring can promote rapport with the client. Absolutely. It all rolls into patient caring interventions and how we care for our patients, whether it's giving them that last bath, whether it's giving them their first bath in the ICU, whether it's having a patient doing post-mortem care. We have to keep those caring interventions intact. These are the 6 C's of caring: compassion, competence, confidence, conscience, commitment, and comportment. I really like this comportment, a caring presence. So sometimes all it really takes is going into the room and the patient feeling like they're cared for. That really makes the biggest difference. Not only do we need to take care of our patients, we need to take care of their families. Okay, family is a basic social unit, a basic unit of society. Family can be defined as a group of people related to each other by birth, by marriage, or by choice. There's different types of families. In a healthy, functional family, roles include the following. We got the caring, nurturing, maintaining continuity of society, receiving love, preparing children, meeting the needs of the members. So there's different things that we need to do to keep our families going and our individual family members from not feeling wasted or going to the sideline. There are 2 career families. That means that both partners are employed by choice or by necessity. That seems to be most of our families now, are either 2 career families or they're single parent, and they have to work by choice is usually the caveat on that. Single parent families is a family with one parent only. Adolescent families, family in which one or more parent is an adolescent. Foster family, consisting of one or more adults caring for more children from other families when the children can no longer live with their birth parents. Child-free families, these are families without children. A lot of times our families without children kind of get a lot of flack too, and we have to be pretty cognizant of that. They often get the question, well, why didn't you feel like you wanted to have children? This can be trifling for some of these families because maybe it was choice or maybe it was not their choice, and there's definitely a cultural thing that we have to keep in mind for those patients to keep ourselves in check, to make sure that we're not imposing our self-fulfilling needs on those families that are child-free. Blended families. A blended family consists of 2 parents with biological children from previous relationships. We're seeing this a lot more often now. A lot of our blended families work great together, and it's becoming a norm. It's really cool. intergenerational families. So we have families with 2 or more generations that live together. Our parents live with us. It's people that can't pay our school loans. We're gonna go live back and live with mom. It'd be really nice. Or our parents are ended up coming to live with us. It's pretty cool. Cohabitating families consist of unrelated individuals and families that live under one roof. This is the family life cycle, the stages and characteristics. Stage 1, 2, 3, 4, 5, 6, 7, and 8, beginning with the family of new carried couples. The stage 2 is childbearing families. Oldest child is an infant through 30 months of age. Let's see here, families with preschool children. Oldest child is between 2.5 and 6 years of age. I guess in stage 3. Because I have a 4-year-old and a 2-year-old, so I'm pretty, so I stick into stage 3. So our stage 4 families are with school-age children. The oldest child is between 6 and 13. Stage 5 is the oldest is between 13 and 20. Stage 6. Families launching young adults. Ooh, all children leave home. Oh, this is hard, right? Middle-aged parents. This is our empty nest through retirement. And then we have our family in retirement and older age. I would know those, like stage 4 is between 6 and 13. I would know those types of things because that's going to be helpful, especially when you're knowing where your families are. Culture. So we have the cultural patterns of thinking with people with living in the social groups, learning, cultural influences, responses to illness or injury, death. A lot of cultures have different responses to death, illness, and injury. Many cultures consider the mind, body, spirit to be a single entity, while others consider it to be different entities. Transcultural nursing involves learning about comparing cultures to provide the care that aligns with their patterns and beliefs. Cultural awareness is to identify our biases along with biases of others. Cultural sensitivity is the knowledgeability about the different cultures. And appropriateness is providing care that's appropriate to that culture for that person. These are your barriers: your language, communication, perception of time. Ethnocentrism is a barrier because that's the believing that one culture is superior to another. Poor access to healthcare, prejudice, and discrimination are all barriers. Diversity. The term diversity refers to an array of differences, communities, and groups. Nurses must be able to work with various diverse populations. We're going to see a little bit of everyone. Therapeutic communications, interpreters, shared languages, awareness of nonverbal cues can help nurses communicate more effectively with patients from diverse backgrounds. Within healthcare systems, resources available to different types of patients depend on a variety of factors. We really just need to know what these patients need. So for example, if you don't know something about their culture, ask. And there's always a way to ask where you're not imposing, hey, is there something about your care that we really might need to help you with that we don't know about? Nurses should be alert to their practices in the group, an environment that impacts the quality of care. Oh, wounds, wounds, wounds. Stage of wound healing. Okay, so the stages of wound healing, we've got normal healing, inflammatory, getting the bleeding to stop, proliferative, new tissues are creative, and remodeling. Look at this. Area of damage is strengthened. Okay? So, complications of healing, dehiscence, evisceration. Evisceration is a medical emergency, so we want to make sure that we know that if something is eviscerated, it is a medical emergency and we need to get the doctor now, so that's something you might need to know. Wound healing, primary intention is the tissues can be brought together. Surgical incision, this is like when there's a nice even cut, a slice, but a secondary intention is the wound has a great deal of tissue loss that just cannot be brought together. Example is a pressure ulcer. Tertiary intention is the delayed closure, and that has the wound is kept open in order to allow drainage and allow the healing to move. Staging. Stage 1 is intact but non-blanchable redness. Stage 2 is the partial skin thickness loss involving the epidermis, dermis, or both, like a blister. Stage 3 is full thickness tissue loss with visible fat. Okay, this can look like just orange. It's kind of like when you peel back an orange and you get that white stuff that sits there. It's kind of what it looks like. The stage 4 is the full thickness tissue, and that's when you splay the orange open. So you're getting into the meat of the orange, and that's kind of what you're looking at, the exposed bone, muscle, and tendons. Order of staging, 1, 2, 3, order of staging, 1, 2, 4, stage, and then 3, because getting between 3 and 4 is hard. So if it's not a stage 4, then it's a stage 3. If you're not sure if it's a stage 4. Stage 4 cannot go to a stage 3 as clarified. Okay, so for example, if you are a stage 4, then you can't go back down to a stage 3. Okay, but this is why staging them is important and why it's usually saved for a wound care nurse or practitioner. If a pressure ulcer is covered with slough or eschar, the wound is considered unstageable because you cannot see the damage underneath. You can see here where all these pressure areas are. So all of the places that are hitting the actual ground or quote unquote bed, all of these places, and you're laying on your sides right here, right here. A lot of times wheelchairs will catch this area too. Your ears, believe it or not, pillows, all those things can cause that skin integrity to be damaged. And then it has a nice outline here of skin, then the soft tissue, and then the bone. I like this. Stage 1, it's a little red. Stage 2, we've got blisters. You see that? Stage 3 is going down there, and then stage 4 is that whole way to the bone. Braden scale. This is really important. We use this in the hospital all the time. The Braden scale is our sensory perception, okay? I would know this chart. Ability to respond meaningfully to pressure-related discomfort. Okay, so that's your sensory perception. Your moisture is the degree to which skin is exposed to moisture. So, for example, skin is kept moist almost constantly by perspiration. Urine dampness is detected every time the patient is moved or turned. So that's pretty significant. So that doesn't mean that it has to be all the time, but every time the patient is moved or turned, they're still kind of moist or dewy. We want to make that constant moisture. Activity, degree of physical activity, if they're confined in bed or if they're chair fast. Mobility, ability to change and control position. Nutrition, intake pattern, and friction shear problems. I would like you to be able to know these 1, 2, 3, and 4. So please just know this chart. This is a good chart to know. I'm going to star it for you guys because this is really a good chart to know from now till ever. Prevention and nursing interventions during the patient, turning the patient every 2 hours, routine skin assessments, proper nutrition, hydration, proper hygiene, a lot of things nutrition-wise we were going to look at. We're going to look at protein, we're going to look at zinc, those for wound healing and for our protein sources. Treatment of first signs and symptoms, we want to fluff and buff our patients as much as we can. We are now in caring interventions. Again, I know there was definitely, there were two people that did this. It's because it's so important. Our caring interventions, compassion, competence, confidence, conscious, commitment, and comportment. Okay, again, we need to go over these things. Our caring interventions. What does caring interventions mean? That means everything that you're doing for our patients. Okay, it's everything. It's making sure you're compassionate with your care. When you're walking in there, you're matching them. You see where they're at, and you're giving them compassion for their issues. I don't care if they're the drug addict that's come in there 1,800 times. Okay, that person really just didn't ask for that type of life. They might be helping along themselves for this life. However, we have to be cognizant of these people coming in, and being compassionate to them does help, and it helps us too. Competence. We need to know our skills. We need to know our judgment. We have to have a good feeling about what we're doing and be confident in what we're doing. So we're competent and confident in what we're doing, and we're conscious, aware of our personal responsibility. Okay, oh yeah, oh I know I need to do this. Okay, commitment, we're doing it as an act of choice. And our comportment are presenting oneself as someone who respects others and in turn demands respect. Maslow's hierarchy is actually a great tool to kind of show us where our patients' basic psychological and self-fulfillment needs are. If our basic needs are not being filled, then our psychosocial and our self-fulfillment needs will be out the wayside. So if we are not getting food, water, warmth, security, and safety, we are not going to have intimate relationships. We're not going to have friendships. We're not going to feel accomplished or prestiged or self-esteem. Okay, so for example, our homeless patient might have food and water now, but they might not have safety and security. Okay, so they're not going to be as intimate with their relationships. They're not going to have that feeling of accomplishment that we're going to see in those Maslow's hierarchy. Caring interventions continues. So the culture and diversity will come back again with our caring interventions. We're going to recognize social impact on beliefs and seek help. Okay, so if we don't know what to do for our patients, or we don't know about ourselves, we need to ask. Assessing personal beliefs and regarding value of social support. Okay, so this means that what's our patient's social support system look like? Does our patient live 500 miles away from home and is not used to that? Did they move suddenly and now are in a new strange place? Or is this something that they live with a bunch of their family and it's a different living situation for them? We need to see what their support system is like. We have to see if their support system is helpful or detrimental to them. So a lot of our patients will come in and let's say mom's a diabetic, but I know she loves these cookies, so I make sure that she has them every week, and when she runs out I make sure she gets more. Maybe we need to talk to them about the cookie bringing, okay, and that might be a problem with their support system. Identifying trusted resources of support and sources of support. This is where our case managers can come in and really help us along with this process. What we need to do for our ethical side is we need to share our concerns and build supportive networks in our job and for our patients. We need to attend workshops and to increase coping strategies on our end so we can help our patients cope with. Caring interventions continued. Grief and loss, this is huge. Non-Western culture rejects such concepts such as palliative care, hospice care, advanced directives, organ donation. Be respectful of these decisions. Chaplains and translators if needed. Just ask your patients. They're going to tell you. Okay, and if they're on the board about something, we can always educate them on their options that we have. If they don't have, some people might be of a certain religion, however, their spirituality says something different. Well, that's not really for me. Okay, so we just want to ask our patients what is for them. I noticed on the last slide that there was stress and coping. We want to make sure that we promote a positive stress and coping mechanism for us and for our patients. These can include yoga. These can include stress-related things that we can do to manage, like our music and exercise, reading, taking a walk outside, nature, those types of things. Safety. Use chaplains and translators to ensure that the information is accurately transmitted to the patient and family. Seek information. Safeguard against insertion of racial or cultural stereotypes, biases, and prejudices that may affect the patient care and safety. Professionalism. Assess self-awareness and self-wellness and recognize when limitations are being exceeded. Be aware of warning signs that might signal burnout, okay? We have to watch out for each other. Okay, if you're super tired that day, don't go in. Recognizes areas of self-care and that are unhealthy and identify solutions to promote wellness. Informatics! What is informatics? Okay, a branch of information engineering. Cool beans. So nursing informatics. These are the different types: nursing, health policy, service delivery, EMRs, HIPAA, yeah. All right. Telehealth, geographic information, and patient education, so your e-health stuff. This is incorporating patient information management. Pretty much informatics, that's exactly what it is information management. Okay, how are we going to take what we have and put it on paper to show that we did it, or put it in a system and show that we did it, and they have a record. Promotes interprofessional collaboration and increases communication. These can go now from place to place to place, and the patients don't have to wait. It's awesome. Computerized medical record, EMR, okay, or electronic health records, EHR, all right, to connect patients with health history and one source information, helps track information over time. And the North American Nursing Association, Diagnosis Association, standardized a form of language. So NANDA is the language where we get our nursing diagnoses. So that's definitely something that's helping. For example, our nurses' diagnoses, that's where we get risk for falls or risk for infection. Pros and cons of the informatics. Ability to collaborate and share. I really like that I can make appointments, change appointments, put appointments in, and everybody knows why. My doctor will be like, oh, so you missed your appointment. Oh, but I see you notified us, and so you won't get dinged with a visit point, which I really like. Allows patients to access medical records at home, which I do constantly on my phone. Removes the barrier to patient participation. They can't hide anything from you anymore. Oh, they didn't tell me I had that diagnosis. Why would they put that on there? It's really interesting because some of the things that we didn't realize we have, we're like, wait a second, when did I get that? Or hey, did I really have my flu vaccination? Those are types of things that it's helping fix. Cons. Security breaches and actual information breaches is actually the biggest problem, and of course our social media problems. Bowel elimination. Okay, so this is not urination, this is defecation. So factors affecting bowel elimination: age, diet, medications, physical activity. Okay, so your age and your diet, that's related. Like, for example, our babies, if you notice, they get constipated when they start eating certain things. In our old people, it happens the same way, only in reverse. Incontinence, flatulence, hemorrhoids, ostomies, ileostomy, loopostomy, and double barrel ostomies. Those are pretty cool. Constipation and diarrhea. The lab tests include the fecal occult test, specimens for stool cultures. That's like your C. diff specimens as well. They're going to be on there. For your bowel and urinary eliminations, we want to take a look at the diets and want to see what type of things are that you eat might cause constipation and might cause urinary or lesser output. When you're looking at salt, and you're looking at those types of things that you're eating, how are they going to affect your bowel movements and also your urination. So let's say that you gulped a bunch of French fries down, and then you went to run, and now your tummy hurts, and you can't pee. You probably ate too much salt, and then we need to hydrate you back up. We need to get your water back in you. Urinary elimination, factors affecting that: low muscle tone disorders, spinal cord injuries, age, mobility, psychosocial factors, pain. I might know of someone that's like, I just can't pee in public, I can't pee, I can't pee. Those are types of things that do affect urination, especially in toddlers and like little ones. They don't want to pee on the potty. They don't like the way it smells. And there's also pain and medications. So if your bladder is spasming, you don't really want to go to the bathroom, or if you're having an infection and it burns, you might not want to go to the bathroom. Specimen collection, clean catch and catheter. UTIs are a complication. Urinary incontinence can be stress, urge, overflow, reflex, and functional. Lab tests are your urinalysis, your urine culture, sensitivities, blood creatinines, and BUN. I'd know your lab values from your ATI for your urinary and bowel eliminations. A lot of times we get stuck on things like intake and outputs too. Intake and output are huge. So if you're eating apple juice, if you're drinking apple juice and you're drinking water and you're drinking even a soda, you're going to still see that come out in your urine and your bowel elimination. So please, I would definitely take a look at knowing your I's and O's and how much 4 ounces and 8 ounces are in milliliters and those types of things, so that you can answer questions like that regarding to nursing interventions. Maintaining hydration, diet including fruits and vegetables and fiber. Stool softeners are definitely something that we can use for constipation. Provide perineal care. We want to keep the areas clean and separate. As long that there is a way to wipe a female versus a male, the front to back method is preferred, so to keep the urinary tract clean and sterile as possible. Okay, and then backwards to the anus where the defecation occurs. Inserting a catheter to relieve or manage bladder distension definitely helps with pain and promotes patient well-being, especially on our end-of-life patients. Sometimes it's very distressing not being able to urinate, having to turn and do those things, especially at end of life. Promoting urination by pouring warm water over the perineal area. They actually did this after I had the C-section. This is a very common way to have your patients urinate on their own. It's very helpful, and it's actually a form of those caring interventions. Physical assessment. We're going to definitely go from head to toe. So for one of the first things you're going to look at is whether or not the patient is alert and oriented. Are they alert to place, person, date, time, place? Okay. Data collection. You're going to do your vitals. You're going to do your history. You're going to do what type of diet they're on. Symmetry. You're going to look at your symmetry and your tenderness to make sure there's no lumps or bumps or masses. You're going to look at your color. If your patient is cyanotic, they're going to have a blue tinge. It might be around their neck, lips, ears, phalanges, so your tips of your fingers. You're going to look at your eyes, your Perla, your Snellen charts, your Rosebaum test, covering one eye to see if they can see. Your ears, the Whisper and Rhine test, your Weber's test. Are you taking gentamicin, experiencing hearing loss? Okay, this is something that you might need to know. Also, you need to know the difference between conduction loss and your other types of hearing losses. Now I'm at a loss for words. the conduction and so that's the difference between Whisper Rhine and Weber test. Size, symmetry, and shape. We're going to look at your heart in your thoracic area. So you're going to assess your aortic, pulmonic, tricuspid, and mitral sounds. You're definitely going to flip over to get the mitral. You're going to use the bell instead of the other side of your stethoscope. You're going to look at symmetry, shape, and size, whether or not your trachea is midline, bilateral rise and fall of the chest. If one side is higher than the other, you're going to document that. You're going to listen to your S1 and S2, your lub-dubs. Your mitral, you're going to look at your maximal point of interest. You're going to listen for 1 full minute. Yes, you need to know you need to listen for 1 full minute. Okay, and now we're going to do your chest. So we're going to listen to your chest, okay, and you're going to listen kind of like this. You're going to go 1, 2, down, 1, 2, down, 1, 2, down, and then go to the other side. See how that works? Okay, the difference between the stomach and the chest. Okay, you're going to listen and you're going to inspect, auscultate, percuss, and palpate. You're going to, your bowel sounds, your organ size, muscle tone, masses, tenderness, and continence. These are all very important. Some of the things you might see for patients that have masses, those might be hernias. The continuation of physical assessment is the skin. We're going to look for breakdowns, lesions, and look at your Braden scale from tissue integrity. Color, pigmentation, edema. Okay, so if one leg is larger than the other, we're definitely going to take note of that and make sure you document, document, document. What must you do right after you do your physical assessment? You have to document. Peripheral perfusion, you're going to look at your capillary refill and your skin turgors. Musculoskeletal, we're going to look for your gait, your range of motion, symmetry, muscle strength and tone, curvature of the spine, and your Romberg test. What is your Romberg test? You might want to know what a Romberg test is for. You are going to look for any abnormalities, any breaks, any old fractures. Next is thermoregulation, normal regulation. The body's surface temperature rises and falls in response to the environment, like it should. However, the body's core temperature remains relatively constant. Okay, so that's why, for example, when we are looking at a patient that comes into the ED, let's say that they come in with a low temperature. Okay, I think everybody remembers this. All right, so they come in with a low temperature. One of the first things that we want to do is we want to place a continuous vital signs, but that's because we want to check this core temperature. So your outside temperature, your phalange temperature may be at a low 90s. However, your core temperature might be where it needs to be or might be slightly higher. So what we do in this case is we actually place a rectal thermometer, and then we can continue. If the patient does need warmed, we can continue with the warming precautions. If the heat loss is, let's see here, if the body produces more heat than is lost, okay, so it's warmer than it's losing, the patient exhibits hyperthermia. So hyper means high, thermia, heat. Okay, so if the heat is less than produced, then the patient exhibits hypothermia, so low heat. Methods of heat transfer. Conduction. So the transfer of heat from one object to another with direct contact. So you have to touch it. So that's conduction. So, and they gave the example, the newborn placed on a metal changing table, the heat from the baby would transfer to the surface, making the baby colder. Convection is the transfer of heat away from by air movement. Okay, an aquatic exercise, the water flows against the moving body, and the water is cooler than the body. Heat from the body is transferred to the water. To maintain body heat, the individual must keep moving. So that's why cold water affects people a lot differently, especially like ocean water when it's cold out there, and it's easy to get hypothermia because our body is giving off that heat to the water. Radiation, transfer of heat from one object to another without contact. Evaporation is the dispersion of heat through the water vapor. So that's our steaming, and our radiation could be like, for example, you're holding off a light or a fire. You don't have to touch the fire, but it'll give you heat. These are our basic definitions of health, wellness, and illness. Health is the presence or absence of disease, a state of complete physical, mental, and social well-being, and not merely the absence or infirmity. So the health is your complete health, okay? Wellness. Wellness is a state of well-being. Wellness focuses attention on the whole of being of the whole being of the individual. So wellness. So overall, how well are you? And a lot of time this has to deal with how the patient feels. The patient might be physically okay, but mentally not in that space. So therefore, their wellness might be perceived as lower than what you see as the physical patient. Illness, a high personal state in which the individual's physical, emotional, intellectual, social, developmental, or spiritual functionality is diminished. These are the historical perspectives on the concepts of health, wellness, and health, illness, and wellness. The word health comes from Old English, meaning wholeness. Health is a quality of life that that is hard to measure, therefore it's very difficult to define. Health is a concept. Concepts are ideas or thoughts that incorporate different elements, resulting in a cohesive whole. At first, health was the absence of disease. However, we can still have a disease and be considered healthy and considered whole in today's views. In the 1940s, the World Health Organization suggested the idea of health as a multidimensional concept, and that not only considers your physical, but also your factors and your state of mind, which I think was a really good move on their part. Wellness is the optimal state of health. As an emotionally healthy person, you can take responsibility for your behavior and strive to meet your emotional needs and remove yourself from your own feelings. It's pretty cool. These are your components of wellness. Environmental components, that's your food, water, air. Occupational components, so that's your personal satisfaction. That's your actual work, what you do with your leisure time, your employment, your education. Your intellectual component is the striving to grow and learn, and how you effectively communicate with your individuals, family, and your career developments. Spirituality, we've been talking about, that's your nature, science, religion, higher power, your own morals and how they relate with your values and ethics. Your physical component, that is how good we're taking care of ourselves, our daily tasks, our physical fitness, our nutrition, proper body fat levels, drugs, alcohol, tobacco, practice of positive life skill habits. Our emotional components, we need to know and recognize, accept, and express our feelings, and accept our limitations. Social components are the within our environment, develop and maintain intimacy with others, friendships, and develop a respect for tolerance with people with differing opinions and beliefs. This is our last slide. We are looking at the aspects of health, wellness, and illness. Many factors affect our definitions of health. So for example, our patients that come in that are our returners, we know them, they've had chronic illnesses for years, actually might have a better sitting as to where their wellness is versus someone that might have an acute illness or that have, let's say one patient's been in the hospital for a month and they've never had to do this and it's terrible and they're so sick, when another patient's like, yeah, I do this like every other month, but I'm all right. So you can definitely see that their life circumstances and the things that are going on in their life might be super different, whereas a patient that might have cancer might have a better outlook on their wellness than someone that has an acute affection. Chronic illness is one that lasts for an extended period of time. That's usually 6 months or longer. Our readmissions are when your symptoms disappear, your remissions of symptoms disappear, and your exacerbations are when symptoms reappear. So that's our COPD people that come in with, okay, their illness has coming out of control. We definitely have to talk with our patients about these things so that we can better control them at home so that they don't have to keep coming back. Illness behavior involves ways that individuals describe, monitor, and interpret their symptoms and take remedial actions. In our sick role behavior, this often includes using healthcare systems to help and may involve dependent behaviors. So this is our abdominal pain patients for pain seekers. This is something that they use. They use the sick role behavior. Oh my gosh, I have abdominal pain. It hurts so bad. It's kind of ambiguous. We don't really know what it is. Oh, I just need that Dilaudid, and then it usually goes away. Make me feel better. Unfortunately, they are dependent. They aren't getting a need that needs filled, especially if they're an addict. It's safer for them to come into the hospital than to go and get stuff for a junkie from a dealer. It's pretty sad stuff. But we have to be aware of this, and we have to be aware that the sick role behavior does have an effect on both well patients and patients that really need it, and patients that might not need it. So for example, we walk in, let's say a patient breaks their arm, nothing else is sore, sick, or hurting, but the patient's acting like, oh my god, I can't do anything, my arm hurts so bad. That's also dependent behaviors. And it's warranted, they just broke their arm. So we just have to be cognizant of that for our patients. Thank you so very much for tuning in to the Basics 2.0. Have a great day. Signing out, DJ Nurse Bauer.